Hello, everyone. Thank you for joining. It's 4 minutes to the hour, and we will get started right on time. So you have 4 minutes and to tidy up your last few things, and then we'll get started. You are all on mute, so you can type away, and I won't hear you. And if you have any problems signing in, just send me a message here in the chat box or at the bottom, and I will see it. So I'd just like to welcome everyone to today's webinar that's being offered by Osteoporosis Canada, Fracture Liaison Services. These are our regular webinars called FLS Works. And today we are going to hear from Dr. Diane Theriault, and she's going to talk to us about the National FLS Audits and their impact on patient care. So while you're signing in and get ready, I will share an overview of our website. And so this is the FLS Hub website that's nested within the Osteoporosis Canada website. And so we have lots of information there, and I welcome you to explore that and learn more about FLS. So among other things, we maintain a registry of FLS sites in Canada. We send out a regular newsletter to anyone who signs up on our network. And as well, we offer a free consultation service to anyone who's looking at starting a new FLS. So this is some of the other items that are on our FLS Hub. So we're going to get started here in a minute. Dr. Theriault is ready to take over. If you have any questions or issues signing in, then please send me a message through the chat at the bottom. Or you can send me an email. I'll be trying to monitor my email as well. If you are not able to hear through your computer speakers, although hopefully you are, then you can also use the phone to call in. If you have questions as we're going through the presentation, please feel free to put them in the question box, and we will try to answer them as it's going, or afterwards as well. We can send out a message to you. Additionally, you will get a survey tomorrow asking how you felt the webinar went. So I would appreciate if you have the opportunity to share that, any of your answers to that with us. So today, it's my privilege to introduce you guys to Dr. Diane Theriault, and she's going to lead us through a presentation on the audit. Dr. Theriault, over to you.
Okay, thank you, Luann. So thank you everyone for participating in this webinar. So it's really our pleasure to show the impact that particularly our own Osteoporosis Canada FLS audits have had on patient care. So I'm going to go over, I think it behooves us to go over why we're bothering with these FLS audits. It's not just a make work project for no reason. And I will very briefly go over the core KPIs that we have for FLSs because they're the foundation of our audits. And then I'll review the results from our first and then our second national FLS audit. So the reason we need FLSs in the first place is that fractures beget fractures. As you can see, after a broken wrist, 14% of patients will come back with another broken bone within 3 years. So that's a fairly high recurrence rate. But some fractures have an even poorer prognosis. So after a vertebral fracture, 1 in 5 will be in with a second vertebral fracture within 12 months of the first one. So that's a huge risk, and that risk is happening very quickly. But the queen of fractures in terms of predicting future fractures is without a doubt the broken hip. So after you break one hip, there's only one more hip that can be broken, and close to 1 in 10 will do so within the next 12 months after the first broken hip. 15% will break it within the first 3 years and 20% within the first 5 years. And if they don't break the other hip, they'll be back breaking some other bone. So 1 in 3 patients will break a non-hip bone within the next 5 years. So we say that not only is a second fracture risk very high, but that risk is very imminent. But something that's often not appreciated is that that risk is even greater when we're looking at the older population. So this is very interesting data that was presented at an osteoporosis conference about a year ago. This is looking at Ontario data. They were looking at government administrative databases, and they were looking at only the population, men and women over the age of 65, and they were identifying them as having had a first fracture between 2011 and 2015. And that entire cohort of patients was followed to a maximum of the end of March 2017. So some of the patients had close to 6 years of follow-up after their first fracture, but some patients only had 2. So they identified over 100,000 first fractures in that time span. And we know that fractures over the age of 65, they're mostly all due to osteoporosis. But if you weren't sure about that, 72% of those fractures were women, which fits right along the lines of the increased frequency of osteoporotic fractures in women compared to men. And in their cohort, 17% of the patients suffered a second fracture, and close to 4% went on to suffer a third fracture during that relatively short follow-up period. Now, how quickly did the second fractures happen? Well, the median time from the first fracture to the second fracture was 555 days, so that's less than 2 years. And the median time from the second fracture to the third fracture was 203 days, which is less than a year. And again, that fits with what we know of osteoporosis, which is typically that once you start having fractures, the new fractures tend to happen closer and closer together. But here's the really worrisome finding. what type of fracture are those second fractures? And as you can see from this graph, by far and away, the single most common second fracture was the broken hip. So you can see that targeting fracture patients at their first fracture is likely to have huge impact because their next fracture is risk is high and imminent, and we have medications that are effective and will reduce their fracture risk by half. So we know that this should be happening, but unfortunately, we have a huge care gap after a fracture in Canada. So this is data that was presented at an osteoporosis meeting in Montreal by the Public Health Agency of Canada in 2018. And this is looking at the proportion of patients over the age of 65 in Canada who suffered a major osteoporotic fracture. So that is a fracture of the hip, wrist, shoulder, pelvis, or spine, and looking at how many of them received a prescription for an osteoporosis medication within 12 months of that break. Now, you can see that they looked at that data going back to 2000 and going into forward to 2015. Women are in red, men are in blue, and you can see that even at the peak, which was in 2009, only 26% of women were offered osteoporosis treatment after their break, and only 17% of men. That is a huge care gap. The other thing you can appreciate is something happened in 2009. The rate of treatment declined significantly, and this is known to have occurred because of overblown, out of proportion fears about our very rare side effects to our osteoporosis medication. By the way, this care gap is a worldwide phenomenon, including that drop since 2009. And you can see that it's been spanning 2 decades. And there's no doubt that worldwide there has been caring healthcare professionals, caring healthcare administrators, and caring healthcare researchers who have tried all types of interventions to try and fix this care gap. And you can imagine that if this care gap was easy to fix, it would be fixed by now. Now I'm going to show you a different version of this exact same graph, just to show you the enormity of the problem we're facing. You can see that the top of this graph here, they've cut it off at 30%. But you know, in reality, this is what it really looks like. That entire gray space at the top here, that's the care gap. That's the patients who have been left behind. Less than 80%, less than 20% of Canadians who suffer a fracture ever get investigated and or offered osteoporosis treatment for their underlying osteoporosis. So that means our care gap in this field is greater than 80%. That's huge. Now, there's a care gap in all things in medicine, but typically the care gaps are in the range of 20%, or if it's bad, it might be 30%. Our care gap is humongous. Now, have we found anything that works? Well, there is one and only one solution that can meaningfully impact that post-fracture care gap, and that's the fracture liaison service. And there's no way around it. There are some very key elements to a fracture liaison service, 4 of which are underlined in red here. You absolutely need a dedicated FLS coordinator, and that coordinator is empowered to do these what we call the three I's of identification, investigation, and initiation of treatment. So they're going to find all of the fracture patients who present to the hospital. They will make sure that the patients get the investigations they need. Typically, that might be a bone density test. And then they will help facilitate the initiation of the osteoporosis treatment. And FLS does work. It's a proven solution. It consistently improves the patient care and it closes the post fracture care gap. It reduces the incidence of repeat fractures, and that's including those dreaded broken hips. It reduces mortality. It reduces healthcare utilization. And of course, it reduces healthcare costs. So it's a very clinically effective and cost effective method. Is it perfect? Well, unfortunately, not. Okay. It is hard to do in FLS. You need to pay attention and be meticulous and try to do all of the steps very well. And even the best of FLSs will not reach perfection. And that's because there are barriers to the success of an FLS. So there's barriers to each of the three I's of the FLS. Now, some of the barriers are intrinsic barriers. So that depends on the way that the FLS is designed or the processes that the FLS does. But the overwhelming majority of barriers are extrinsic or completely out of the control of the FLS. So let me give you a few examples. So at a hospital with a very busy fracture clinic, they see enough fracture patients that they know that they should have a full-time FLS coordinator. But unfortunately, because of funding restrictions, they've only hired a half-time FLS coordinator. So, of course, there's no way around it. That hospital will still be leaving half of the fracture patients behind. Or there may be an issue with access to bone density, or there may be an issue with poor access to osteoporosis medications on the provincial pharmacare program. Or, and we've discussed this already, there may be fear of our osteoporosis medications, the kind of fear that's led to that drop in the care of that osteoporotic patients get since 2009. So let's have a look at some of these things. Now, we did a very interesting exercise in 2018 with all of the Canadian FLS coordinators. And in that exercise, we asked them to identify at their own FLS the barriers that they had to providing good, optimal osteoporosis care to their patients. And we asked them to tell us whether that was a barrier to the first eye, the second eye, or the third eye. So I'm not going to go over this in detail, but just to tell you that there were many barriers to the first eye, but they all fit on one slide. Same can be said about the second eye barriers. However, for the third eye, we had already identified from the FLS coordinators that there were many barriers. So one slide, two slides, three slides worth of barriers. So when we start an FLS, there's a all too easy cascade of losses of patients that are inadvertently left behind. So a few might be missed at the identification step. A few might not be able to go for their bone density tests or their other investigations. And then there'll be a few that for some reason or other, you just simply can't end up starting them on treatment. Now, let's assume that an FLS is 80% effective at each one of these three steps. So we're going to start with 100 patients. So if they're 80% effective at each of the steps, well, they're going to miss 20% of the patients at the identification, so they're down to 80. And if they're 80% effective for investigations, that's going to bring them down to 64. And if they get 80% of those 64 patients on treatment, that's going to end up being 51. So you can see that an FLS that looks on the surface to be really, really quite good would still end up leaving behind half of the fracture patient. So if you could just tweak that FLS by a little tiny bit and make them 90% effective at each one of these steps, how much of an impact might that have? Well, actually, that has a huge impact. You can see that now you end up with 73 patients out of the 100 ending up on treatment, right? That's a big improvement. Now you're only leaving behind 25% of the patients. Now, in terms of what to measure, so we want to strike the right balance between asking the FLSs to collect and monitor some data, but not a whole lot of data. So here are three just examples. They're extreme examples to make a point here. But here are three FLSs. They're at hospitals that each see 600 fractures a year. And they all end up with very poor results because they only end up with 48 patients on treatment. How did they get there? Well, you can see that just measuring this measurement might not do the trick because each FLS ended up there in a different way. So you can see this first FLS here, where it's missing the boat completely, is it's not identifying the patients. This FLS is identifying a good proportion of the patients, but they're missing the boat at the investigation. And this one here, they're doing great up until the point of starting the patient on treatment, and that's where they flop. So obviously, you need to identify or measure and monitor enough different parameters to be able to help the FLS sort out where their weaknesses are and where their areas for improvement may be. So that leads us to talk about our core FLS indicators. We've tried to limit those numbers to not overburden the FLSs. And we've got it down to 4. So we're talking about the first eye, the second eye, and the third eye. And I should add that we have extremely well-defined numerators and denominators for each one of those KPIs. And what that means is that we get the results from the FLSs and we're able to very well compare with other FLSs. Now, for the most part, none of these can an FLS reach 100% except for the second eye. So for the first eye and the third eye, there's no expectation of any FLS reaching 100%. We expect they can reach possibly 80% or so. Now, for the first eye, we've actually divided it. We've subdivided it in two parts. We do the first eye for the hip fracture patients because all of those patients are found in the inpatient orthopedic ward, whereas the wrist and the shoulder and the pelvic fractures, that's the non-hip, non-spine fracture patients, they are seen in the orthopedic outpatient clinics. And so the barriers that can be identified are going to be very different for the hip fracture patients than it's going to be in the outpatient clinics. Okay, so that is very valuable information for the FLSs. Now, is this a make-work project? Are we doing this? Is this just Diane Theriault saying the FLS should do this? Or is it just Osteoporosis Canada saying this? Or is it more important than that? So, first of all, it is absolutely essential for each FLS to assess their own performance. That's a given. If you don't measure and you don't monitor, then you possibly don't even know that your model's not working that great. To be able to optimize the FLS, to make it reach its full potential, it needs to be able to compare with other FLSs. Now, that can only be done if they participate in a national FLS audit, like those of Osteoporosis Canada. And in fact, participating in national FLS audits is an essential criteria of any existing national or international document that lists clinical standards or best practices for FLSs. So it's not controversial, it's a given. And in fact, it's beyond just a recommendation. National FLS audits are now completely mandatory for all FLSs in the UK and in New Zealand. Okay, so in the UK, the National Health Service mandates that all FLSs must participate in their ongoing um, um, national audits. Now, this is what their reports from the UK look like. Okay, as you could see, each hospital is listed and they have a total of 11 KPIs that they're monitoring. We decided to go with a lesser number, so we're only monitoring 4 KPIs. And of course, we are a voluntary audit because we do not have the ability to mandate it because we don't have a national health service. Now, before I give you the results of the audit, I do want to put a word of caution in. National FLS audits, they evaluate the FLS. They do not evaluate the FLS coordinator. The national FLS audits, they evaluate the strengths and the weaknesses of the FLS itself, and any weakness that's going to be in there is going to be because of a significant barrier, either an internal barrier or an external barrier. It will not have to do with the FLS coordinator not doing their job. So everybody's familiar with this Plan, Do, Study, Act cycle, okay, which is important. And we know that, now, this is an interesting graph. I'm going to go over that. So we know that without FLS, less than 20% of patients will ever be started on osteoporosis treatment post-fracture. So for argument's sake, I've put it here at 15%. That's the bar that we have to go beyond to be effective. If an FLS sets themselves up and they do all of the key essential elements, that dedicated FLS coordinator, good attention to the first, the second, the third eye, they're likely to get to about 50% effectiveness. To get beyond that means you have to work at removing the barriers, and you keep repeating that PDSA cycle over and over again. You look at your own outcome measurements. You need to compare to other FLSs with audits, and ideally you compare your FLS with benchmarks for those KPIs. In fact, this is not just helpful for the individual FLS, but when national audits are done, this is helpful for the entire collective of FLSs. Because as the FLSs keep doing these cycles and keep improving, the standards for the FLS go up with time. So, for example, if I give you an example, the gold standard for FLS back in 2007 is no longer what we accept. In fact, that 2007 standard for FLS is no longer acceptable. It's not even called an FLS today in 2020. That's because we've tweaked and we've found all the processes in an FLS that are super important for the FLS to be effective. And indeed, the FLSs are getting more and more and more effective as those standards go up. So let's talk in general about our FLS audits. First of all, they're meant only for the non-Ontario Osteoporosis Strategy FLSs. So the Ontario Strategy has 22 FLSs across Ontario, and because they have such a big program, they already are involved in doing their own provincial audits. So these Osteoporosis Canada National FLS audits are intended for non-OOS FLSs only. Our first audit was on a cohort of patients for 6 months. So they were enrolled in the FLS between April 1st and September 30th, 2017. Now, that's when they're enrolled. You now need a bit of time to do the investigations and then eventually initiate osteoporosis treatment. So we allow for a 6-month follow-up on each of the patients. So this follow-up period ended March 31st, 2018, and so this is the 2018 audit. 12 FLSs participated, and that was 80% participation rate, so that is wonderful. Our second audit was on the cohort of patients between April 1st and September 30th, 2019, with the follow-up to the end of March of this year. We had 15 FLSs participate in that one, and that was an 88% participation rate. Keeping in mind that these are voluntary audits, so this is very good participation rate, and that's kudos to our Canadian FLSs for recognizing the importance of this participation in this work. So here are the results from our first audit. At that time, there were 13,098 patients enrolled in that 6-month period. And I'm giving you first the KPIs for the first eye hip, first eye non-hip, non-spine, and second eye. I think you can appreciate that there is a huge weakness seen in the non-hip, non-spine. So, and I think you can probably appreciate that it's much easier to identify hip fracture patients that are sitting in a bed on a ward compared to identifying fracture patients in the middle of a very, very busy orthopedic clinics. So you can see that there are some more barriers there. Now, if we are successful at this, then it would mean that with the second audit, we should have improved a bit. Okay, so drum roll on this, and sure enough, we're relieved to see that the premise that we had does pan out. So this is proof of concept that doing all of this work leads to improved patient care. So there are more patients in the second audit, in part because there are 3 additional FLSs, but also in part because the older FLSs are now enrolling more patients than they had in the previous audit. Okay, so you can see that the one with the lowest score ended up with a very remarkable improvement. So that's great. Now you'll also notice that I've kind of kept the third eye quiet for a minute because I want to expand a little bit on that. So remember when we did that exercise, we had already identified that there were way more barriers to that third eye than any of the other 2. So if that is true, then we should almost predict that the results for the third eye might not be so successful. And that's indeed what we found in the first audit. You can see that that was our lowest score for all of the KPIs, and a bit of a disappointment, quite honestly, for everybody, because we're trying so hard to make sure that we are able to help the patients prevent that next fracture. And of course, without osteoporosis treatment, there's no way that we can do that prevention. So what have we done? Now, let's analyze what the barriers might be. Now, first of all, you need to understand again, this is not about the FLS coordinator not doing their job. The FLS coordinators in Canada cannot prescribe osteoporosis medication. So, this is basically completely outside of their control. So, this is all based on barriers that are external to the FLS. Does that mean that the FLS should just wash their hands of this and say, well, we have no control over this, so let's not do anything? Well, that's not how a good FLS uh, does things. In fact, most of the FLS coordinators have seen this challenge. They see that the barrier is external, and they've tried to work around to see if we could fix or reduce the barriers as much as possible. Now, this is going to be a bit of an oversimplification, but the two groups of barriers that we can look at is a reluctance to initiate either in the patients or the patient's family relatives, or a reluctance to initiate by the prescriber or the patient's family physician. So let's look first at the, again, oversimplification, and this is very broad strokes. Look at the reluctance in the patients. Well, the first one is the fact that we know that patients deny the fragility fracture of their the nature of their fracture. Now, the FLS coordinators will tell you, and research now, proves that too. In almost 100% of the wrist fracture patients we see, for example, they they will tell you, I fell hard. If anyone else had fallen like I would, they would surely have broken their wrist too. Um, Yet we know that we only see these fractured wrists after the age of 50 for the most part. That people fall all the time in their 20s and 30s, and they don't end up with those same fractures. So recognizing that that is a barrier, it's a perception that we need to try and gradually change amongst the patients and their relatives. Osteoporosis Canada and all of the FLS coordinators across the country have partnered together to develop some tools to initiate that conversation with the patient. So this is just two panels out of a brochure that looks at trying to look at the importance of why bones break, why fractures matter, and how the FLS is involved in trying to reduce the risk of future fracture. What about the fear of osteoporosis medication? That's the reason why we're seeing this drop. This is a worldwide phenomenon as the media have been, harping on these extremely rare side effects to our medications. So this is a drop that's been seen worldwide. So again, in partnership with the FLS coordinators across the country, we've developed some tools. Here's one that talks about myths of osteoporosis, and I've just taken a few random myths, and we give the facts, and again to initiate that conversation between the patient and the FLS coordinator. What about the cost of osteoporosis medication? Surely the FLSs can't be held accountable for that. Well, I'm going to give you an example where big kudos are warranted for the Alberta FLSs and also to the Alberta government for recognizing the importance. So in Alberta, when the FLS started, there was some restricted access to some of the important treatment alternatives, particularly important for hip fracture patients. And so the Alberta FLSs worked on a proposal that they gave to government to ask for expanded coverage of osteoporosis therapeutic options. And I'm pleased to report that they were successful. So that has, again, it's the FLS, it's supposedly out of their control, and look how good they've managed in Alberta with their proposal to government. And again, kudos to the government themselves for looking at the evidence, supporting that great care should happen to the patient. So, what about the prescriber's reluctance to initiate? Well, we know that often the prescribers don't recognize the importance that that fragility fracture has in terms of predicting that future fracture. They may be leery of the medication side effect. Remember, I showed you that the older patients are the more likely patients to end up with new fractures, and they're the most likely to benefit from treatment. And yet, in practice, the FLS nurses tell us time and time again it's the exact opposite that happens. There seems to be a general reluctance to treat the very elderly, patients with dementia, and patients who are long term care residents. These are the patients who are most likely to benefit from our drugs, and they're the least likely to be initiated on treatment. So, in terms of the efforts across the country, well, Osteoporosis Canada already has evidence based guidelines that they published in 2015 that are specific to the management of osteoporosis in long term care. Over and above that, Osteoporosis Canada has supported education both in person and through webinars like this one for family physicians and physicians caring for patients in long term care facilities. In this FLS Work series, we've already offered two separate webinars looking at management in the older population. And locally in the provinces and the regions around FLSs, the FLS champions, the FLS coordinators, or the FLS medical leads have provided education on osteoporosis again to family physicians and to physicians caring for long term care facilities. So, this was how we were after the first audit. We have put an enormous amount of activity on that third eye, both locally in the FLSs and collectively as a group of FLSs. So, fingers crossed that we should have an impact. And we did. Okay, so this is good, but I think you can all appreciate that that still remains our biggest Achilles heel. So, about that third eye, it's gratifying to see the improvement because we've put so much effort into it, but it remains the single biggest challenge faced by more Canadian FLSs. We have a long way to go still, and we're going to need even more intense efforts to bring that up where it should be. So, we've talked about measuring outcome measurements for the benefits of the FLS individually. We've talked about comparing to the other FLSs who are in audits. What about benchmarks? Well, in the UK, they have established benchmarks. That's this color coded, okay, and they've used very intuitive red, amber, green type of benchmarks. So, with red being the worst, green being the best, and the amber in between. So, we find that very useful, and we've used that color coding to do our own benchmarks here at Osteoporosis Canada. So, we start with the green, and green is defined as at or near optimal. And remember, I said no FLS is ever expected to reach 100% on some of these KPIs, notably for the first and the third eyes. So we've set that bar at 80%. For the second eye, that's the only one where potentially an FLS could potentially reach 100%. And so we've set the bar much higher for that green zone at 95%. We recognize that the FLSs, when they first start, they find some barriers, they improve, they find new barriers, they keep tweaking up. So we've allowed for a fairly broad amber zone with 30 percentage point spread. so 50 to 80 here and 65 to 95 here. And below that is the red, which means highest priority for service improvement. So let's have a look at our results. So these are bar graphs, so these are the individual FLSs, and we're looking right now at the 2018 audit. We're looking at the KPI for the first eye hips, and you can see that a little bit more than half of the FLSs were in the amber, no reds, so that's good, okay, and quite a few FLSs in the green zone. So in the second audit, we're going to see more bars because we have 15 FLSs in the second audit. And you could see that now 50% of the patients are in the green zone. So a little slight tweak up on that one. Still no reds. Okay, what about the first eye for non-hip, non-spine? So now you're only seeing 5 bars because currently if we exclude the anterior strategy, there's very few FLSs in Canada that actually target the orthopedic outpatient clinics. Only 5, so there was only 5 in the first audit and the same 5 FLSs in the second audit. So no reds, one single one reached the green zone. In the second audit, slight improvement, 2 have now reached the green zone. What about the second eye? Okay, well, we already said the second eye was easier to reach a higher score. So you can see that a good chunk of FLSs were in the green zone with only 4 in the amber zone. And despite the fact that we have more FLSs in the second audit, now only 2 are still in the amber zone. And I will say that one of the things that allowed the FLSs to improve their patient care in this area is to switch from using a tool called CAROC to using another tool called FRAX, which has better data and better flexibility in terms of being able to use the diagnostic information for the patient. What about the third eye? So you need to remember now that the third eye is our biggest challenge. So not surprisingly, for the third eye, there's a significant number in the first audit that were in the red zone, big red flags for them, and only 1 reached the green zone. In the second audit, more FLSs, but you can see that now we've got much more in the amber zone and 2 in the green zone. So overall, the movement, if we can summarize it, between the first audit and the second audit, the movement has been for the first eye and the second eye from amber to green, and in the third eye, a general improvement moving forward on the benchmarks. So to summarize, we've proven the concept that national FLS audits do help improve patient care overall. We've seen an improvement in all of the KPIs, and we're able to identify where we still have big problems, which is mostly the third eye at this point. What's the next steps? Well, each individual FLS has received their results. So they all received the report, which gave them their results. It will allow them, their report card gives them the first audit result, the second audit result, so they're able to compare with their own results over time. We give them the range for each FLS and the median, so they're able to compare themselves to other Canadian FLSs. And now that we've set some benchmarks, they're also able to compare their own FLS to those benchmarks. Now, they'll all be involved in looking at their own analysis to identify their weaknesses. And once they identify those, to see what are the potential internal and external barriers that they see. And then it's about finding a solution to those barriers. Occasionally, Osteoporosis Canada is also able to provide further analysis Just based on the data we get, we're often able to say to an FLS, for example, we see that your big weakness is for some reason you're missing all your shoulder fractures. So when we see that, we're able to give that information to the FLSs so that they're able to hone in a little bit closer to what might be their biggest barrier. We also offer support. We've often assisted some FLSs to be matched up with another FLS. So if FLS1 that's been in operation for 10 years has already identified a barrier and fixed it, and then this brand new FLS that's just starting has just identified that exact same barrier, we can match them together so that they can learn from the other FLS. Whatever solution they found in the older FLS to fix that barrier, it's possibly going to help this younger FLS as well. On the national front, we need to review our FLS KPIs, and we'll be doing that early in 2021. We need to make sure that they are optimal. I don't think we're going to be changing the KPIs for the first, second, or third eye. But remember, we only use 4 KPIs, and you saw that in the UK they have 11 KPIs. So is it time for us to consider adding additional KPIs to our audits? So that's something to be decided. There's also going to be new Osteoporosis Canada clinical practice guidelines published next year. We will want to make sure that everything we do at Osteoporosis Canada is in alignment with those new guidelines. So we will update the KPIs if needed also. Now, usually our audit cycles are 2 years. So you do the audit measurement, you get a report in the first year, you have 1 year to review your results and tweak your model, and then you have again another audit. So it gives you 1 year to tweak and improve, then you measure again. This year, we've decided to allow the FLSs to have 1 extra year of breathing space because of the pandemic. Many FLSs were suspended temporarily because of the pandemic. They're now mostly all back up and operating, but of course it's a new normal. So we want to leave the FLSs to focus on the immediate priorities, which are really how do we do this without access to BMD testing right now? How do we do this without this? How do we do this in the new normal? So the next audit will be on the cohort of patients that will be enrolled in the FLSs between April 1st and September 30th of 2022 with that 6-month follow-up period. So that audit will be again published in 2023. So if you want more info on FLS or on the audits, I strongly recommend that you visit our FLS Hub. On that homepage for the FLS Hub, you will see an icon if you wish to join the FLS Network. The FLS Network gets periodic newsletters with updates on new developments in the FLS world and in FLS science. And we also offer a free FLS consultation service. So for free, we will review a new proposed post-fracture care model before they implement to make sure that we can tweak it as best we can to set them up for success from the get-go. And, there's no need to reinvent the wheel. We already have tons of FLS tools and templates, for example, for form letters to go out to family physicians, et cetera, et cetera. So we would share those with you. We would help with the training and possibly provide some mentorship to new FLS staff. And of course, we assist people with their continuing quality improvement because they fall into the audit cycles at Osteoporosis Canada. If you have any questions or you'd like to contact us, you can reach us at fls@osteoporosis.ca. So I'll now take questions. So I'll turn it over to Luann.
Thank you, Dr. Theriault, for that great presentation and helping us all understand the importance of an audit to the FLSs in Canada. I don't see any questions just yet, so we'll give everyone a few minutes. And again, if you have a question right now, type it into the question box and I will read it to Diane and she can answer it. Or if you sign off and think of something, you can put it in the survey tomorrow, or you can send an email asking the question. Also, we will be archiving this presentation on our website, on the FLS Hub website, within the next few days. So if you missed something and you want to review it, or if you'd like to share it with your peers, or in particular a healthcare administrator that you might know at another site who does not have an FLS, then that would be great as well.
If there are no questions, we can certainly, conclude. But I'd certainly welcome anybody who has questions can certainly reach out to Luann or at fls@osteoporosis.ca, and we'd be happy to answer your questions.
Great. So on that note, thank you very much, Dr. Theriault, for sharing your knowledge with everyone today, and hope we can all work together to move FLSs forward in Canada. Thanks, everyone, and we'll talk to you next time.